Hello, my name is Dr. Amy Power, and I'm the Walter J. Hamlin Professor and Chair of the Department of Dermatology at Northwestern University Feinberg School of Medicine in Chicago, Illinois, USA. Today, I'll be talking about supporting healing in epidermolysis bullosa with a particular focus on innovations and new directions for care. Junctional and dystrophic forms of EB are part of a large group of rare congenital skin disorders characterized by blisters. The others are EB simplex and Kindler syndrome, so four different subtypes clinically. Junctional EB comprises about 5% of the cases. These are all autosomal recessive disorders, and they're characterized by blisters in the middle, right between the epidermis and the dermis, in a place called the lamina lucida. These all affect the hemidesmosome, which holds together the epidermis and dermis, and are characterized by blisters that heal with atrophic scarring. And one of the clues can be granulation tissue, particularly around the mouth, the nose, the fingers and toes, and in the upper airway, with a lot of issues related to hoarseness and airway patency. Dominant and recessive dystrophic EB together represent around 25% of cases. These occur with blistering at a deeper level, that is in what's called the lamina densa, which is in the very bottom of the basement membrane zone to the dermis area. These patients who are affected by dystrophic EB have blisters that lead to scarring, and this scarring can lead to great deformities with marked decrease in function of the hands and feet in particular, but also joint area contractures. Their scarred areas of healing also have inflammation and little tiny inclusion cysts called milia, which are a clue to this diagnosis. Nail abnormalities, as in other forms of EB, can be seen. EB is associated with pathogenic variants in at least 16 genes that are important for cellular integrity and the adhesion of the epidermis to the dermis. So, failure of these structures that provide mechanical stability to the epidermis and then that basement membrane area between the epidermis and the dermis are what result in the malfunction and in the skin fragility. Junctional EB arises due to 7 distinct pathogenic variants, and these affect the hemidesmosome region, which includes several different proteins. Now, these proteins are either totally wiped out or are pretty much totally dysfunctional in causing junctional EB. They can be one of the 3 different proteins of laminin 332. It can be collagen 7. It can be integrin proteins or proteins that affect integrin function. So, all involved in the hemidesmosome function of that particular area of the basement membrane zone. Dystrophic EB arises due to pathogenic variants, almost always in the collagen 7 gene. And this results in either insufficient or very poorly functioning collagen 7 proteins. These collagen 7 proteins make up the anchoring fibrils, which connect to the basement membrane zone and loop into the upper dermis. Now, there's also another group that's pretty common. In fact, the most common form of EB, occurring in about 70% of cases, and that's EB simplex. Now, there are a few different genes involved in this, but most commonly either keratin 5 or keratin 14, which sit in the basal cells of the epidermis and are the ones that kind of connect to the basement membrane zone. Very important for holding together those epidermal cells to the ones below. And when we don't have these keratins, our basal keratinocytes just basically collapse. Now, the wounds in EB are frequently persistent, or what we might call chronic. But I will note that in 63% of those with dystrophic EB, for example, it is not just those chronic persistent, but in fact, in 63%, wounds that will close and then open and close and reopen. And that's part of the problem, too, is that it's not like some types of wounds outside of EB that people may get where it finally heals and it stays healed. This closing and reopening and closing and reopening creates a cycle that leads to a lot of pain, itch, susceptibility to infection, associated chronic inflammation, and all of this comes together to diminish the quality of life for affected individuals. It's very important to recognize that there is a wide variety and severity within all of these different types of EB. There may be some who really only manifest pretty much all on the skin. And then there are others that have a wide variety of other comorbidities that can impact them. These may be oral or gastrointestinal, musculoskeletal, hematologic, ocular, neurogenital, involving the kidney, and even cancer, with a marked increase in the development of cutaneous and even mucosal squamous cell carcinomas that can metastasize, and this is particularly common in the type called recessive dystrophic EB. These may be very difficult to detect because the ones on the skin are sitting on a surface that is not normal skin, but has many of the characteristics of cancers of the skin, like being thickened or being atrophic or being ulcerated, and certainly very difficult sometimes to know if a cancer is even occurring as a result. Now, you asked about psychosocial impacts, and of course, so many patients who have particularly the more severe forms of junctional and dystrophic EB have terrible anxiety, have depression, have this very poor quality of life as a result. They often can't be mainstream, so their peer relationships are poor. And we need to really pay attention to this because this depression in particular can severely impact all of these other systems and just make their condition that much worse. Currently, there are no curative treatments for EB. I think that would take really genetic engineering. But we do have two topical medications that are FDA approved for taking care of dystrophic EB, and in one case, junctional EB as well. One of them is the birch triterpenes or oleogel S10, and this is for both dystrophic EB and junctional EB. This is an agent that had been available for wound healing, was tested in EB, and was found to meet its primary endpoint of complete wound closure within 45 days, occurring in 41% of those on the oleogel S10 versus only 29% on the control gel, with an equal frequency of adverse events. And this is for individuals who are at least 6 months of age and is just applied daily to the wounds. There is an interesting gene therapy approach now that's out for dystrophic EB that's called BVEC. This is a topically applied gene therapy in which the normal collagen 7 gene is inserted into a vector that has inactivated herpes simplex virus and can produce the collagen 7, basically turning these cells into a factory. Now, this BVEC is also approved for 6 months of age and above, but again, just with dystrophic EB because it's just providing the collagen 7. But the phase 3 trial data showed complete wound healing at 6 months in 67% of those on BVEC versus 22% of those on placebo. And there was only one adverse event, mild erythema, that was considered to be related to the BVEC itself. Now, I also want to mention another therapy that should be coming out in the next months, which actually corrects the collagen 7 gene from that patient in their own keratinocytes, allows expansion of this and then grafting of sheets for recessive dystrophic EB. This is called PZ cell. And the phase 3 trial data looked as a primary endpoint at wounds that at 24 weeks, or about 6 months out, had at least 50% healing. That was shown in 81.4% of those with the PZ cell treatment and only 16.3% of those that were the controls. What's also really important to note is the reduction in pain, with a mean reduction in pain at week 24 of -3 for those treated with the graft versus less than -1 for those who were untreated controls, with an AE frequency slightly higher for those with the PZ cell than for the untreated controls. Now, I do want to also mention that there are several medications in development for EB simplex. These are various in their pathomechanisms, but in the case of one that's called diacerin, it is an anti-inflammatory medication. We see a trial ongoing now for injections of botulinum toxin, which probably influences the pain, but also seems to promote healing and stabilize. And then another called Tolisure that is an agent that actually helps to clear preferentially the defective keratin protein. The caregiving team for any given patient with EB is going to, of course, depend very much on what their problems are. Primary care doctor, the dermatologist always need to be involved, but the rest can be very broad depending on that patient. So, for example, surgeons, plastic surgeons, orthopedic surgeons may be involved in helping with the wound healing or the treatments that we've been talking about. Or, for example, orthopedic surgeon may be involved in helping to release joint contraction, or in those who have recessive dystrophic EB whose scarring leads to the mitten deformities of the hand. We do degloving procedures with surgeons. That could be plastic surgery, orthopedic surgery, to try to separate the fingers and give better function. Now, particularly junctional EB, where there is an inherent issue of the teeth, or dystrophic EB of the more severe types, where there are dental caries from decreased ability to salivate and a reduced ability to open the mouth because of scarring, we have to use our specialized dentists to try to help to manage the enamel defect and the junctional EB and the caries in those with dystrophic EB. There may also be hematologic involvement with anemia in these patients, and we may be giving iron injections. We may be giving transfusions, so the hematologist needs to be involved. For those who have eye issues, again, both junctional EB and more severe dystrophic EB, the ophthalmologist would be involved. Of course, pain management for all these patients, nutritional management for all these patients who fall off the growth curve, which of course is seen in every patient with more severe disease, and anything from gastroenterology, particularly to deal with the reflux that they may have, or putting in the G tubes that may be needed to help them with nutrition, and because the esophagus can close off and reduce their ability to take in liquids and food in addition to the oral blistering that can occur. Physical therapy to help because they get these contractures, and then, so importantly, social services, psychologists to help with their quality of life issues and their psychiatric, psychological issues that come along from having this terrible, terrible group of chronic diseases. And let's not forget our nurses. Our nurses are critically important with all the wound care management in particular, and then the day-to-day issues that come up for these patients. We really need to follow these patients carefully, especially those who have more severe disease. We bring them in regularly for careful skin and wound assessments. Management, though, is so multifaceted. I alluded to it a little bit in talking about the multidisciplinary care that's needed. But I would reiterate that this is really a team approach between these doctors and the family and the child, if old enough to help, with the shared decision making that needs to be done. Now, of course, we need to think about infections. This is the most common complication that we see. We need to be on the lookout for infections and treat these rapidly because with these open wounds, these patients can easily become septic. We, of course, need to protect them from trauma so that we reduce, if at all possible, the development of these wounds or the reopening of wounds that close. Now, to heal, of course, we need to have proteins on board. We need to have red blood cells delivering oxygen. So, malnutrition that occurs in these patients needs to be managed. The anemia needs to be managed. The itch, the pain need to be managed. These need to all be managed on a regular basis. They're very common issues across the board with more severe junctional and dystrophic EB. I mentioned earlier the risk of squamous cell carcinomas. These metastasize very quickly. The earlier they are found, the better. So we need to be regularly monitoring for these. And if they're there, we cut them out. And still, this is the greatest reason for adults who have these serious forms to pass away. I would want to mention, too, that no matter where someone is across the world, there may be a baby born with EB. And so many hospitals, so many doctors are unfamiliar with EB and need to understand better what are the guidelines for inpatient management of EB. I want to let all of you know that there's a wonderful publication that just came out this year, 2024, in the Journal of the American Academy of Dermatology. It is by Abreu Molnar et al. And comes out of the Pediatric Dermatology Research Alliance, in which experts from pediatric dermatology, but also a variety of experts from other specialties, came together and through a modified Delphi process, created consensus-based best practices for hands-on inpatient management of EB, both in the neonate and then also in the post-neonatal period. It's hoped that these will greatly improve comfort with caring for patients and improve management. There were 10 areas of focus that were identified. Now, obviously, these will be used to different extents depending on that individual patient's clinical context related to procedure risk, EB subtype, severity, and then, of course, the patient and family preferences. In fact, I would strongly recommend that anybody who's at a hospital that's going to be taking care of a neonate with EB access this reference, print it out, and put it right in your neonatal nursery so you have this handy. So when that baby comes in, they're right there ready for you.